Hello, my name is Dan Drake, and I am a benefits specialist here at the Colorado Mental Health Institute at Pueblo. So I handle benefits for our discharging patients. Um, so thank you for the opportunity to explain the many barriers to expedient patient discharge. Our patients are reliant on SSI and SSDI benefits for income. SSI is the foundation for receiving Medicaid, as is SSDI for Medicare. These are insurance programs needed to pay for medication, treatment, and to some extent, skilled care in the community. A patient has SSI and SSDI benefits suspend after 30 days of incarceration or hospitalization, whichever comes first. SSI benefits will terminate, that is, completely go away after 1 year of incarceration hospitalization. So this means that those benefits must be reapplied for or applied for in the first time for the cases of people that have never had them. In the vast majority, our patients need this done prior to discharge. Currently, the means to renew SSI and SSDI benefits is in jeopardy from the Social Security Administration's change in policy toward the institutes. CMHIP is allowed only 8 cases a month at maximum to process. 8 cases. And furthermore, CMHIP must compete with DOC for those same 8 slots. So where this puts us at a disadvantage is DOC knows exactly when an inmate's incarceration will end. We do not always have the benefit of that knowledge in our discharge planning. This has caused the slots to process SSI and SSDI claims to be scheduled in advance for months. So right now, at the beginning of November, we are already scheduling for January. And soon January slots will fill up and we'll be looking at February, probably by the end of this month. Furthermore, the institutes do not share the same protections to expedited processing that DOC has. We have been allowed to, for lack of a better term, ride the coattails of their protected process known as the Memorandum of Understanding. But SSA changes this at will for the institutes. So we just have a business process, not an official MOU. We are not allowed. Oops.
Can I have a question?
Sure.
When you say 8 spots per month with DOC, is that just based on what's on this campus, or is that based on all of DOC in the whole state?
Well, this is in relation to the field offices that process pre-release claims. So for the Social Security offices are sort of broken up in what's called district offices.
Yeah, okay, I get it.
So Pueblo handles this certain district, and up for Fort Logan, it's going to be Littleton that handles their district.
I get it. Okay.
So for us down here, we've got 8 slots between DOC and between us.
Okay. Thanks for that clarification.
Sure. Let me see. Like I said, I don't want to be too dry, but we are not allowed appointments at discharge to activate benefits at the Social Security Administration field offices. So that's another problem, is that this requires that patients sometimes their first contact discharging from the hospital is going to be in a Social Security field office for 5 hours. And our patients have a variety of developmental, mental, and physical symptoms that can make such a long stay difficult. Any delay in processing at the field office sometimes results in delays to their insurance. We need the protections afforded to DOC and more conditions that apply specifically to our vulnerable population. So kind of just speaking back to what I just said is if there's any delay at that first contact with the field office, that creates a chain reaction of other things. If their SSI, SSDI doesn't get put into place, that can result in issues with their Medicaid and their ability to pay for treatment, medications, and their stay in assisted livings. So related to the insurance issue is the activation of long-term care Medicaid needed to cover placement in assisted living and skilled care facilities. Due to the above mentioned issues, there are delays in activation of Medicaid. However, there is also close consideration of resources, sometimes several years old, expired, or irrelevant for eligibility. We have had Medicaid cases denied because we have been unable to provide a bank statement for an account unused for 5 years with 50 cents in it. We have also had cases denied due to an inability to provide financial information for a former spouse that a patient has not lived with for years and does not know the current whereabouts of. We need HCPF to recognize the unique situations our patients are affected by and make special considerations for those. Okay, I'm going to try to go fast. Supporting documents like Colorado IDs and birth certificates also produce a unique challenge to our patients having a fast discharge. Because one cannot get a birth certificate without a valid ID, and vice versa, our patients are in a catch-22 situation. A DOC ID can be used as a valid form of supporting documentation for an ID, but our institute's patient IDs are not accepted. Despite the fact that patient identity has been thoroughly vetted, and they have sometimes been with us for years, we need our IDs to be as accepted as DOC IDs. We need special accommodations from the Department of Revenue to recognize the unique predicaments our patients are in beyond the exceptions processing that already exists and is currently an imperfect fit. And lastly, mental health centers need to be held accountable for not accepting patients who wish to discharge into their service areas. Excuses such as patient Medicaid is inactive are one of the many obvious attempts to block our patients receiving vital treatment services in the communities they want to live in. Tedious and redundant processes that are done in the supposed need of thoroughness end up adding days and weeks to benefits processing and placement, sometimes causing the benefit process to need to be redone due to expiration of applications or placements refusing a patient. These are some of the most pressing areas of concern, but there are many others. I am always available for further discussion or questions, and thank you for your time.